I'm Dan Collins with Mercy Medical Center in Baltimore, Maryland, and you're watching Medoscopy. If medoscopy sounds like a screening you might need as part of your annual physical, you're not far off. For a medoscopy is a procedure of sorts as we use our special scope, the video camera, to delve into all things medical, to educate, engage, and enlighten. Today, we're speaking with Dr. Vadim Gushchin, noted surgical oncologist who leads Mercy Medical Center's HIPEC program, the Melanoma and Skin Cancer Center, and Gastrointestinal Oncology. That's a lot of titles. How would you describe yourself, what you do?
Well, I'm just a surgeon who loves to see patients and treat them from various cancers, whether it's melanomas, skin cancers, or gastrointestinal cancers. Actually, it's sort of like investigative work. Prior to patients getting to the operating room when I do the surgeries, you have to unravel lots of stuff. So that's what I do, that's what I like.
Now, how did you end up taking this route? How did you get into medicine? Was that something you always wanted to do?
Pretty much. I don't recall myself doubting who I'm going to be. And interestingly enough, I don't know why. Maybe because my grandmother was a surgeon, maybe because my older sister went to medical school. I do not know, but I never had a doubt in my head that I'll be a physician first and then a surgeon.
Now, where did you study originally?
I was born and educated in Moscow. I finished my high school there and went to medical school there. So I started in the USSR and finished when there was no such country. So I finished when I was the Soviet Union dissolved, and I was in the Russian Federation. So in 1993.
So you went from the Soviet Union to the fall of the Soviet Union. Can't help but want to know, what was that like to live through that?
I think it was a very fascinating time, but it was everyday life. So I didn't even notice. I remember once we were let's go to Red Square to witness how the flag is coming down. USSR flag, the red flag with sickle and hammer is taken down. And it was one of those days in December 1991. Nobody thought twice about that. And now we're kind of describing it as a historical moment, but it didn't feel like it when you were growing through these events.
Eventually, you did make the decision to come to the United States. What made you make that decision? Why not just stay and practice medicine in Russia?
Well, at some point I thought that I'm not becoming a physician that I would like to become. And I read medical texts, medical textbooks from the United States in English, and I saw a drastic difference between the reality in Russia and what's it could be.
So you've had that opportunity to see medicine in Russia, medicine in the United States. For you, what's the difference?
Well, it's a very deep question. The difference is that patient is really in the center of my practice in the United States. I cannot practice medicine any other way. I'm kind of indoctrinated the American way. So the patient is in the center of what I do. I don't come to the operating room to operate. I see the patient first, and I try to make sure that I'm helping him or her. So that's the big philosophical difference, and everything else stems from it.
It sounds very much in line with what we talk about at Mercy, the concept of patient-centered care, that everything comes from the patient. You're working with them, you and the patient or a team, to try to determine what's going to be the best course of action for that individual to get the best outcome so they have the best quality of life and so forth. Now, as you mentioned, that seems to be more of a phenomenon you've seen here than in Russia, but you're trying to make a difference about that, are you not?
7 years ago, I started teaching oncology for young Russian physicians online. And I was struggling to describe the difference, what I'm trying to accomplish, and what the difference is between the approaches and what the patient-centered care is about. And little by little, I started internalizing this very vocabulary that you just used. And the words became, kind of acquired a different meaning for me. So if you describe this phenomenon like word by word, and sometimes it takes like an hour to spell what patient-centered means. That's quite different. Actually, it's reminded me when my son was growing up in the United States, I gave him to listen to songs that I loved when I grew up. And it would take me probably an hour and a half to explain what the words in that song meant. Just literally, you have to go to history, and you have to go a little bit into Russian language, and he was fluent, and he is still fluent in Russian. And still, you have to make all these different connections, and to describe one song, it would take an hour and a half, like a 3-minute composition. So, and that's what I found myself describing what patient care is about in America to young physicians in Russia.
So you're not merely just translating language, you're trying to translate the ideas, the concepts, as you mentioned, certain terms have a historical context to them that if you don't know what it is, you're not going to perceive it. That's quite a challenge, I imagine, for you. But you're seeing some results, are you not?
Yeah, and that's what's exciting about this project. My wife sees me like coming out of I usually teach on Saturdays morning, so sometimes it happens at work, sometimes at home when I'm not on call. And my wife witnesses me coming out of the room where I just did the teaching session, and I look happy. And I feel happy, and that's what kind of, I don't know whether it's because I see the results or because of the process itself, but the results started to kind of creep up probably 2-3 years after I started. You see the attitude changed. You start hearing the words that I just said in a different context and with the same meaning, and it was wonderful.
Now, you've done a lot of work also locally in terms of just educating the public here in the U.S., or at least in the Maryland region, with our Woman's Doctor program and some of the other news segments that you've been part of. You've talked about everything from signet ring cell carcinoma, melanoma, skin cancer, minimally invasive surgeries for colon cancer, and of course your work with HIPEC, hypothermic or heated intraperitoneal chemotherapy for our viewers who might not know what HIPEC is. That's what the HIPEC stands for, but what exactly is it?
Well, HIPEC actually, it's a catchy word for a much larger concept. It all started with rare malignancies that nobody wanted to treat. Nobody knew how to deal with these patients. And they were universally sent to home or hospices because nobody can help them. The chemotherapy wouldn't work for different reasons. The surgeries seemed unimaginable because there's so much tumor, you just cannot take it out, right? Some surgeons, enthusiasts, and my teacher, Dr. Paul Sugarbaker, was one of them, suggested that you actually, if you spent enough time in the operating room, like 10, 12, 14 hours, and take all the tumor out, and then treat the invisible cells that probably are lurking around with the heated chemotherapy, these patients may have a second chance. And they did.
Speaking of the patients, and you mentioned this is working very well, or I know myself, I've met HIPEC patients who were, again, told that, get your affairs in order, you have a few months, and now they're 15, 16 years out since their surgery. And the patients come together every year for a particular event that I know that you're involved in, the Heated to Beat It event. Can you tell me a little bit about that?
Yeah, it started slightly more than 10 years ago when patients themselves wanted to show each other that they exist, they're alive, and they're actually living a pretty good life. And it was impossible not to be drawn into this when you see patients actually smiling and thanking you and thanking each other when they come together. It's kind of you become even uncomfortable that you're some sort of a hero and you're just doing your job. Then I realized that actually these events are important for them. And again, they need to see each other. They need to feel that they're in the community. There are many of them. They're not freaks of nature. And they just had the misfortune of having peritoneal carcinomatosis from different types of tumors, and they feel empowered to send a message that it's not the end of the road.
Last year, due to COVID-19, the global pandemic, there was just a virtual celebration. But that virtual celebration gave us a chance to learn about a particular hobby of yours, and we're going to talk about that right after the break.
The surgical oncology team at Mercy treats all variety of cancers, including common ones like colon cancer, liver cancer, pancreatic cancer, as well as rare ones like the appendix cancers, mesothelioma, and others. We also have very tight collaboration between other physicians. We talk to them several times a day. Patients appreciate the team approach.
Medical oncology and surgical oncology are all on one floor. We're a very cohesive group. We meet weekly to discuss patients so that we can provide a consensus of cancer care for each individual patient.
We individualize not just to a patient and what their personal needs are, but we are individualizing to things like what genes are not functioning properly. And that's a revolution. That's a whole new way of thinking about cancer. We really are exploring so many more options in treatment.
HIPEC is heated intraperitoneal chemotherapy. Patients come to us with advanced cancers. The tumor covers all organs of the abdominal cavity. We remove a lot of tumor in the operating room. Once it's done, we add heated chemotherapy in the abdomen. This treats microscopic disease that we can see with our eye.
HIPEC has now become the standard of care in a variety of tumors: mesothelioma, appendix cancer, more in colorectal. For ovarian cancer, over almost 25 years now, we already have shown in people who have recurrence with ovarian cancer that will do very well.
Nanoknife, or irreversible electroporation, a way of ablating, not removing, but killing a tumor, for example, for patients with advanced pancreatic cancer who are not candidates for removal of the tumor. After chemotherapy and radiation, we are able to provide nanoknife treatment to the tumor to provide some benefit in terms of controlling the disease and prolonging survival.
We love what we do, and for us it's an honor to see patients doing better, and We have a big team at Mercy with other physicians, nurses, and researchers that make things happen, and that's why it's so good.
What Mercy offers is really the personal nature of the care that's delivered here. From the very beginning, when the Sisters of Mercy started this institution, it's been patient-centered care. It's not a new concept to Mercy, it's one that's been refined here and has been going on here over 100 years.